Today's topic of discussion will be obstructive uropathies in children. Obstructive uropathy means blockage of normal flow of urine anywhere along the urinary tract, and this is one of the important cause of chronic kidney disease in children. So the different types of obstructive uropathy, starting from number 1, meatus. There will be meatal stenosis and phimosis. Number 2, in the anterior urethra, stricture, valve and polyps. And number 3, posterior urethra, you get posterior urethral valve, stricture and polyp. So the highlighted portions, phimosis, posterior urethral valve, are more important, so we'll be discussing those two. And number 4, in the urinary bladder, there might be diverticulum, calculi, bladder neck hypertrophy, neurogenic bladder. Number 5, pelvic-ureteric junction obstruction. This is one of the commonest anomaly, so we'll be discussing this also. So this might be caused by kinks, bands, adhesions, aberrant vessels and calculi. And number 6, uretero-vesical junction obstruction at the site of ureter and urinary bladder. The obstruction might be caused due to calculi, ureterocele. And number 7, vesico-ureteral reflux. And this is also one of the important cause of obstructive uropathy, so we'll be discussing this one also. Now come to the discussion. So number 1, starting with phimosis. Phimosis is adhesion of prepuce to the glands, and this is congenitally or physiologically present till the age of 2 to 3 years, and then it gradually resolves spontaneously. So in less than 3-year-old children, this condition usually we cannot diagnose as phimosis until the scarring of the prepuce is very obvious. And in this, they present with recurrent balanoprosthitis, there is smegma collection, and then they have a recurrent urinary tract infection, so they present with the increased frequency and urgency of the urine. The treatment for this is circumcision and or slit in the prepuce can be done. So this is phimosis. Right side, this is a normal condition where the foreskin is separate and the glands are visible, and left side is phimosis where the skin is covering the glands, so glands is not visible. Now come to number 2 condition, that is posterior urethral valve. Due to the presence of the valve in the posterior urethra, the urinary bladder and then all the above tract are all dilated. So this is the most common obstructive uropathy that is seen in male children. The incidence of this is 1 of every 5,000 to 8,000 male births, and 70% cases can be prenatally diagnosed by doing ultrasonogram, which shows hydronephrosis. Now come to clinical presentations. It is variable in different age groups. In the newborn, you get abdominal mass, which is actually a palpable urinary bladder, and these babies may present with the ascites, respiratory distress, urosepsis, delayed voiding or poor urine flow. And during infancy, there is urinary dribbling, failure to thrive and acute kidney injuries, and also urosepsis can be a presentation. In the toddlers, you get a recurrent urinary tract, and then there is voiding dysfunction with the dribbling of the urine. And at school age children, male children, they present with the urinary incontinence or nocturnal enuresis can be there. So diagnosis is by ultrasonogram number 1, which shows a wide prostatic urethra, thick walled urinary bladder, and then upper tract dilatation, as you can see in the picture. And the gold standard for the diagnosis is by micturating cystourethrogram, which diagnoses posterior urethral valve as well as the VUR. 50% of the posterior urethral valve is associated with the vesico-urethral reflux. So if MCUG is normal, that will exclude the posterior urethral valve. So this is one of the very important investigation for this condition. Treatment during the neonatal period will be transurethral catheter, putting a catheter through the urethra, or doing a vesicostomy that is making a per abdominally, making a opening and then taking out, putting a catheter and then draining urine from there. And at the older age, when the valve is properly developed, then you do valve ablation. So by posterior urethral valve there can be various complications. Number one is renal function impairment, which occurs in 25 to 40% of the cases. Hydronephrosis can develop with the scarring of the kidney also, and then 50% is associated with the VUR, and there is vesical dysfunction can occur. Now come to pelviureteric junction obstruction. So this is a condition where there is obstruction at the site of ureter and then the renal pelvis, ureter and renal pelvis. This is a congenital anatomical malformation where there is obstruction at the renal pelvis to the ureter. It is more commonly associated with ectopic kidney, malrotated or horseshoe shaped kidneys. 60% cases it is left sided and then unilateral, and 10 to 25% can be bilateral. If it is unilateral only, it is usually diagnosed at the adult age or any time when they are doing other investigations, because it has no symptoms. And if it is bilateral, and then only they may have symptoms and then diagnosed earlier. It is more common in the male than the female, and it is always nearly due to kink at the ureter, and the other causes may be bands, adhesions, aberrant vessels or calculi. It can be diagnosed in utero by doing ultrasonogram, like in the posterior urethral valve. Clinical features. Very obvious clinical feature is abdominal pain with a positive flank mass, and both resolves with the passage of large volume of urine. They may present with the flank pain, suprapubic pain, and they may have vomiting, hematuria, dysuria and oliguria. Now come to the diagnosis. Diagnosis is by ultrasonogram, which shows hydronephrosis, hydroureter and then renal cortical thickness. And Doppler USG can show the aberrant vessels. Treatment is surgery. Pyeloplasty is done, and then it gives a 98% success. So surgery is very helpful, and some cases require nephrectomy. Now come to the last condition, that is vesico-urethral reflux. This means retrograde flow of urine from urinary bladder to the ureter and renal pelvis. From down to up it is going, so it carries the ascending infection. So normally ureter is attached to the urinary bladder in an oblique direction. So if it is attached in an oblique direction, it is creating a flap valve mechanisms. So this prevents reflux. The reflux can be of two types, primary and secondary. So primary reflux or primary VUR is occurring in otherwise normally functioning urinary bladder or urinary tract. Here the problem is that anatomical defect, instead of oblique attachment, it is implanted bit straight, so the tunnel is short and that flap valve mechanism is not there, so it cannot prevent the reflux of urine. So reflux of urine occurs in the urinary blood and to the ureter and up in the kidney. Secondary reflux or secondary VUR is associated with obstructed or poorly functioning lower urinary tract, so which occurs in posterior urethral valve, neurogenic bladder, inflammatory process, absent or weak detrusor muscle, duplicated ureters and ureterocele or calculi. So in all these conditions the urinary tract functions poorly and the reflux can occur. So this is known as secondary reflux. And number 3 type is inherited trait. So this is a genetic condition. If the mother has a VUR, 50% of her offspring can also have a VUR. And if one sibling has a VUR, risk of another sibling having VUR is 35%. So this is a genetic or inherited type of VUR. So totally there are 3 types of VUR. So now how the reflux is causing damage to the kidney. It causes damage to the kidney in two ways. Number one, by the back pressure of the urine to the kidney. So from the urine is flowing back towards the ureter and to the kidney, so creates a pressure and then causes kidney damage. Another second type is by ascending infection from the urinary tract to the ureter. So from the urine is a good media or source for growth of the organisms. So this urine is flowing back to the ureter and to the kidney, so infection is carried throughout the urinary tract, which may damage the kidney earlier or fast. Now come to classification by international study. According to this, there are 5 grades of the VUR. So diagrammatically, I'll just go fast with the gradings. So grade 1 VUR means the blue color is urine. Okay, so here the urine is flowing back only to the lower third of the ureter, and there is no dilatation of the ureters. Grade 2 reflux, urine refluxes to the whole of the ureter and then up to the ureter, and there is no dilatation. Number 3, grade 3 VUR, urine refluxes to the ureter and to the calyces, up to the calyces, and there is dilatation of the ureter. Number 4, grade 4 VUR, the urine is refluxing back up to the whole of the ureter and calyces, and there is a marked dilatation of the ureter. VUR, you can see the reflux is so much that there is tortuosity of the ureter. All ureter is becoming tortuous, and there is dilated ureter, and then calyces all are dilated. Sign symptom, 80% are seen in females. This is diagnosed at 2 to 3 years of age, usually discovered while evaluating for other causes like urinary tract infection or while doing investigation for other symptoms. VUR alone is never causing any symptoms. The child presents with a recurrent urinary tract infection or has a high blood pressure, so while investigating these conditions, you discover the reflux. And the gold standard for diagnosis is by micturating cystourethrogram, which shows all the dilated urinary blood. So radionuclide studies are required once you diagnose VUR. So here DMSA scan, dimercaptosuccinic acid scan, is done, which shows the anatomy of the kidney or the renal scarring is seen. Radionuclide cystourethrogram will show you the site of VUR and posterior urethral valve. Endoscopy can be done through which you can directly visualize the lesion. So besides that, functional assessment can also be done by the diuretic radioisotope scan. So in this DTPA scan, that is diethylene triamine pentaacetate scan, or MAG3 scan, mercaptoacetyl triglycine scan, is done, which shows the excretion function of the kidney, and then the glomerular filtration rate is shown, and also excludes the degree or site of obstruction. So another functional assessment can be seen by doing the serum creatinine level. Now come to treatment. Many children do not require any treatment because usually they go away spontaneously, they recover by the age 5 years. But the goal of treatment should be to prevent infection, number 1, and number 2, to prevent the scarring of the kidney so that the kidney damage is prevented. So most of the cases require antibiotic prophylaxis. Grade 1 to grade 5 refluxes require antibiotic prophylaxis until the reflux resolves. So prophylaxis means usually 1 to 2 years we give low dose antibiotics. And then surgery is done for grade 3 to grade 5 VUR. So here reimplantation of the ureter is done into the bladder at a normal angle, so that new valve can be created, so reflux can be prevented. Thank you. We'll see you again in next class.